So, good morning, everybody. My name is Kathy Leonardson. I'm the chairman of the Legislative Action Committee for the League of Women Voters of Massachusetts. And welcome to the Meet the Specialists for Healthcare. This morning is our topic with Val Pasquantonio and Janice Goodall. And I just want to mention what the Legislative Action Committee does. We're the legislative arm of the state of Massachusetts League of Women Voters. Our committee is composed of over 20 specialists in various areas, and you can go on the State League website and see all the different areas in which we're advocating. Right now we're monitoring about 160 different bills. And what we do is we write testimony. We might ask for help from league members at certain points in the legislative process to move the legislation forward. And we're very excited to have our specialists in healthcare this morning to bring us through topics on 5 different bills. So I'll turn it over to Val and Janice. Thank you.
Thank you, Kathy. Can everyone hear me? And we'll just assume everyone can. I have to have a big shout out to Kathy for all she does. She's amazing, and a very big thank you to her, because the whole idea of having Meet the Specialist came from Kathy, and it's a marvelous idea. I also have to thank from the bottom of my heart Taylor, who is helping me put together this slide presentation. I can get the slides, but I can't get them to work. So Taylor is helping in that respect, and I certainly appreciate that. But most of all, the person that I appreciate most is my co-specialist, who is going to be here with us today, Janice Goodall. When I started here as a legislative health specialist, I knew nothing about this, and Janice took me under her wing, and I am only 3 years into this, and I'm still learning, and she is kind and generous and knowledgeable, and she's just recovering from a horrible accident. And I am so excited today because it's my first opportunity to actually see her. And we got to speak for a few minutes before this began. So hopefully Janice will be able to participate and give us some of her very, very deep knowledge of all of these, bills. What we're going to do is there are 11 slides, and I'm going to go through the 11 slides with everybody mute and ask you to please type in all of your questions to the chat. Taylor will be monitoring the chat, and at the end of the 11 slides, which should take no more than an hour, I hope far less, we will answer all questions. We will have discussion. But first, let's make sure that we're all on the same wavelength and everybody understands all 5 of these bills. The first slide, if I can get it.
You're going to want to go to play at the top.
Play. Yes. Thank you. See, Taylor? Without Taylor, we're lost. Okay, now I can press this button, right? Whoops, we gotta go back. All right, the first slide talks about, how do I get this slide centered? Or do I just put people up the top?
That's about as centered as it's gonna get.
Oh, okay, well, we'll just deal with it then. For the 192nd session of the Massachusetts legislature, we have chosen 5 bills, and you have before you their nicknames and what they do. The first bill is called the Caregiver Tax Bill, and this is a new bill. It's the first time it's come before the legislature. The second bill is the Community Immunity Bill, which is simply a process bill, which I thought would be so easy, and it isn't. The next is called the Midwife License Bill, and this corrects a ridiculous catch-22. There's the Public Health Bill, that also has another name, SAFE 2.0, and that establishes a viable public health system. M4A is a single-payer health insurance for Massachusetts residents. It is one of the League of Women Voters priority bills in this session, and we'll be spending most of our time on M4A. And M4A, by the way, stands for Medicare for All. Should I not be able to advance this?
You should. Are you using the arrow key?
I am.
Okay. Maybe click on the window. Click on the PowerPoint window or the presentation window.
Share or?
Nope. Stay sharing, but just put your cursor on the actual window with your presentation and click.
The whole thing has gotten very big, so the presentation isn't there anymore.
Just click somewhere and then you should be able to start. There you go.
Okay.
Now you can use the arrow.
Thank you, Taylor. The Family Caregivers Tax Credit. This is H2979S788. And this is new this year. The League of Women is supporting it and asking for a larger tax credit. What this does is establishes a tax credit of, at the moment, it's the Senate bill says $1,000. The House bill says $3,000 for any family, for family caregivers whose gross income is less than $700,000 per year. Eligible expenses are things like improvement to the home, purchase or leasing of equipment, obtaining necessary goods and services. When we brought this to the LAC, the Legislative Action Committee, because it was a new bill, we didn't know whether they would accept it, but they accepted it 100% really fast. It was a unanimous vote. And the only thing they came back with was, we should ask for more than that $3,000. People who take care of their family members at home have a lot of out-of-pocket expenses, and they are saving the Commonwealth of Massachusetts tremendous amounts of money that would normally be spent on taking care of people who need support, medical support in the home rather than in a facility. We are asking that you email your senator and you email your representative and ask them to sponsor this bill and to vote for it. And moreover, this bill is right now in the Joint Committee on Revenues, and the hearing is going to be this Monday. I think that's the 13th, Monday. You can see from the slide who the chairs are, both the House chair and the Senate chair. You can see their telephone numbers and you can see their emails. If anybody has any stories about caring for people at home and the expenses that are involved in that and are willing to speak up about it, talk to Taylor, talk to me, put it in the chat, and we'll try to help you get involved and perhaps even if you would like to go to the Joint Committee on Revenues hearing or submit testimony to them. All the testimony we can get, the better. This is a really great bill. It's necessary. The people who take care of their loved ones at home are doing it not because they want money, they're doing it for love, but it is a huge financial burden as well as a wretching thing to have to do. So if we can help them, that's great. So this is the Family Caregivers Tax Act. The reason I am doing this with these slides is so that you can go back to the slides when they are online or on our website and get all of the information that you need. Remember, if you've got questions, stick them in the chat. The next bill we're going to talk about is the Community Immunity Bill. This is a process bill. This should have passed with no problems. It changes nothing. This bill changes nothing. It keeps all the laws in place that have been in place for years, literally 50 or 60 years. What it does is that it establishes a standardized reporting for collection of data and mandates the reporting of that data in bulk to the state of Massachusetts Public Health Department. Now, this law saying that you have to, collect the data and report it has been on the books for years. What we're talking about now is children who go to school, children who go to day camp, nowadays children who go to, who have daycare. And there are laws that say that children, going way back to when I was a little kid, have to have certain immunizations before they go to school. Diphtheria, tetanus, whooping cough, all of those kinds of things. But there has been no standard way of collecting that data. Basically, every town does it differently. Sometimes every school in every town does it differently. And sometimes it doesn't get done at all because, hey, school nurses have a lot to do. It is now the age of computers, and there are plenty of ways to standardize this. And this bill says, okay, we now have the ability to have everybody put their data into one place when they're collecting it, and then to take that data and report it not as single pieces of data, but as a collective data for each school or daycare center or camp. The advantages of this is that the Massachusetts Department of Public Health will know where the resources are needed should there be a problem, and parents will be able to make informed choices regarding their immunocompromised children. Right now, somebody who has an immunocompromised child and has 3 or 4 elementary schools that child could go to has no way of knowing which school would be safer for that child because that child cannot get immunized. So it's important that the data be collected. We ask you to contact your representative and senator and to ask them to sponsor this bill and to vote for it. And more importantly, to tell them that this is just a process bill. All we're asking them to do is that the nurses can standardize how they collect the data and how they report the data. That's it. Nothing else has changed. This poor committee, it's now in the Committee for Public Health, had to listen to 15 hours of testimony from people who didn't read the bill and had all sorts of weird thoughts about what the bill is about. Unfortunately, sometimes our representatives and senators don't have the time to read the bills either, and they get the idea that this is about some new kind of immunization. It's not. It's just a process bill. So please, please, please do that. And also in next month, if you could, go ahead and contact the Joint Committee on Public Health and ask them to please vote this bill swiftly and favorably out of committee so that we can get this process going. All right, let's see. Aha, out of. Oh, and I should say on the prior bill, I said it about 5 times, it changed nothing, but just in case. It does not change anything about religious exemptions, nor does it change anything about medical exemptions. That prior bill, Community Immunity Bill, say that fast 10 times, changes nothing, except how the data is collected and standardized. Out of hospital births, oh, this you're gonna love. This is correcting a catch-22. And this has been around for a long time. And it's also a good beginning of the M4A discussion. Midwives who have something called a Certified Professional Midwife Certificate, a CPM. This is the gold standard of midwifery in the United States. And most states, the majority of states, recognize CPM certified midwives as perfectly fine, wonderful people who are professional and have and can safely and professionally do home births for healthy mothers with normal pregnancies. These are midwives who start with prenatal care and go all the way to postpartum, as well as in home birth. Since the CPM requires such stringent credentialing, the state of Massachusetts allows CPM midwives to practice without a state license. The Commonwealth says we don't need to give them a license. They have a CPM certificate. They're golden. No problems, right? Aha. But here we have the catch-22. If there is no state license to put on the health care insurance form when requesting insurance reimbursement, no insurance payment is allowed, including mass health patients. All right, let me say this another way. At this moment in time, and for all past years, a woman must pay out of pocket to have an at-home birth because midwives do not need a license as they have CPM certificates. Health insurance forms require state license in order to pay. So the only persons who can have in-home births are people who can pay out of pocket. Talk about your inequitable situation. We'd like you to contact your representative and senator, your personal representative and senator. Explain this ridiculous catch-22 to them and ask them to sponsor this bill, to vote for it, and to correct this catch-22. The committee is right now in the Joint Committee of Public Health. We'd like you very much to contact them and yourself and ask them to please swiftly and favorably get this out of committee. I know it sounds ridiculous that just because you don't fill in a little blank on a form, you wouldn't get paid. I mean, really, that's ludicrous. But I can tell you, as being in practice for 45 years, I'm a dentist, that if you don't fill in every little form, it will be rejected. And it's not one of those things you can call up and say, no, no, no. It's in the contract. You don't have a state license. You cannot be paid. And since Mass Health has been farmed out to a private insurance company to oversee, the same happens for Mass Health. So this is just horrible situation. So anything you can do it, but please explain the catch-22 to your Congress, to your representatives, your state representatives and state senators, and try to help them get this thing taken care of. It's been on the docket or it's been around, let's put it that way. This has got to get fixed. It's so foolish. It's not foolish, it's sad. It's really sad. I'm sorry, I get angry about stuff like this. Okay, out of hospital births. Onward. One of the many reasons I love this particular bill, it is a bill that says in its title what it is. So we don't have to worry about anybody having to read the bill to understand what it's about. It is an act relative to accelerating improvements in the local and regional public health system to address disparities in the delivery of public health services. SAFE 2.0. Okay. This bill establishes a professional public health system that has equitable state funding to serve all the residents of the Commonwealth wherever they may live. Massachusetts is one of the few states in the Union that does not have a state-funded and good public health system. SAFE 1.0 was a pilot project with temporary funding that allowed small towns to come together and form large enough areas so that they could hire, they had the money, they could hire a professional public health nurse and a professional public health social worker. What this bill does, it establishes permanent state funding and mandates to have a public health network for all the residents of Massachusetts. It's important that you understand that the boards of health and all of those kinds of things, how they're elected, how they're chosen, who they are, none of that changes here. The difference here is that these boards of health, et cetera, are mandated to hire public health nurses and social workers, are allowed to get together with other towns so that they can have enough people to actually have these nurses and social workers busy, and it funds it from the state. They're no longer having to be locally funded. That's one of the problems with our public health right now. It's locally funded, so little towns can't afford it, or towns that don't have as, well, to be honest, as wealthy a tax base as others, don't have a good public health system. Obviously, if this was in place before the pandemic, then things would have been very different. Tracing would have been different. Good information would have been different. There would have been a nurse and a social worker available to all the Commonwealth, all the citizens, all the residents of the Commonwealth, and how we received and got our vaccinations most likely would have been quite different. This is a bill that is in progress. I just talked to them this morning. Where we are right at this moment in time is that ARPA, which is the American Rescue Plan Act of 2021, has finally, ARPA funding, let's see, how do I say this? The ARPA for Massachusetts, which came out to about it's more, let's see. Bottom line, this bill, the public health bill here, SAFE 2.0, is that out of the ARPA that was just passed last week, sort of in a back room, well, we won't go into that, 200.1 million was put towards establishing a public health system over the next 5 years. Also, this bill and the people who are behind it, the coalition that is behind it, and we are also behind it, have gotten to the point where there has been funding for the next 2 fiscal years for this this public health system to happen. And at the moment, prior to last Thursday and Friday, when the ARPA finally got passed, there was an amendment hoping that this bill would be passed with the ARPA. That amendment didn't go. So now bill is back with the Joint Committee on Public with the Joint Committee on Public Spending. So, no, not in public spending, public health, Joint Committee on Public Health. So we ask you at this point in time to contact your local state representative, your local senator, and ask them to support SAFE 2.0 and to see to it that it gets out of committee, which is the Committee on Public Health. Let's hope I got that right. And the Joint Committee on Public Health. I'm quite certain that's where it is. And I will check that out and get back to you by the end of this session. This got changed literally 5 minutes before we began because the Massachusetts Public Health Association, which is putting this whole coalition together, had their meeting at 9 o'clock this morning. And I asked them to contact me, and I got the information right before it came. So this is in motion. This bill's going to pass, and it's going to be marvelous, but it needs all the help we can get in letting everybody know that this is important, that we want it, we've got the money for it. We just need the actual bill to get out of committee and to be passed. Janice, did you want to, are you still with me? And did you want to say anything about any of those 4 bills before we go to the M4A? I don't know whether Janice is with us or not.
Yeah, I am with you. I think on this last bill, I think just wrote in chat, I think it would be interesting if the pandemic had been handled by the public health system and not the market or politicians. Right. The mandate would have a lot more authenticity because it wouldn't be considered red or blue related. And I think people would have found it much more acceptable and paid attention to it.
Right. And as we've always talked too, is if you know your public health nurse and you know your public health social worker and they're part of your community on a daily basis, then you're going to listen to them much more carefully. They have credibility, and it's a good way to get good information to the people who need it.
Yeah, on the bill about paying for caretakers, I'll write testimony for that. I've done a lot of caretaking of my family, and then my daughter bringing me home to her house and the expenses that we paid. Now, I'm not eligible for the rebate, but and the tax cut, but there are a lot of people who have those expenses who would be eligible, and it would help because taking care of somebody at home is very expensive. Those expenses would be paid for if I had gone to a nursing home or my mother had gone to a nursing home. And so you've actually saved the state a lot of money, and you've taken it out of your own pocket. So that's a bill that should definitely be supported.
Yeah, we like this bill, don't we? We both like it a lot. And the LIC liked the bill too, the caretaker bill. I think I'm very hopeful that it will pass. And anything anybody can do for any of these 4 bills to explain them to their legislators would be extremely helpful to get them to the finish line. So shall we go to the priority bill now? What do you think?
One other thing, Val, somebody in chat wrote about the cost for the providers of home births who want to be certified. And I'm going to apologize for this, but that was a question before we considered, when I was considering the bill. And I remember questioning it, and I got a reasonable answer. And I'm ashamed to say that between anesthesia and trauma, I have forgotten what the answer is, but I will look it up.
Okay.
It seems to me that somewhere this was taken care of when we considered supporting the bill.
Yes, it was. Yeah. And as those of us who have various licenses know, that you have to pay for your license. So the actual getting a license for the, I know that's not the question you were answering, but the actual getting of a license should not be a cost to the state. But, you know, although what I remember was $3,000, $4,000, $5,000, somewhere in there, that was out of pocket for a woman to have an at-home birth with a midwife. I might have that wrong, but that's a lot of money, especially if you already have insurance. So this is a catch-22 that really needs to be taken care of. Okay.
Valentina,
And-
I mean, so clarifying question there, because if you give birth in a hospital setting, then like, I don't know that they bill it separately, but you end up seeing a lactation consultant, and you like, there are many people like audiology checkup, and like you get, like if there's, let's say, jaundice, then care for that is immediate and bedside. So I just wonder, is part of the reluctance of the state to legitimize home birth because the market isn't yet providing the comprehensive level of services that the number of employees that are present in a hospital setting does?
Okay. Oh, well, first of all, let's remember that these are professional human beings, the midwives. They're not going to let anything get by them. And there is no questions about that at this moment in time. The safety, the fact that all of those things happen. A midwife is not somebody who says, oh, I'm going to do it all by myself and I'm not going to bring other people in. All of these other people come in, and all of these other people, believe it or not, have their Massachusetts license. So I had the experience of doing a lot of work with 2, 3, and 4 month old, day and week old in the last part of my practice, and some of them had midwives, and some of them had what do they call it? Birthing centers, and some of them had, you know, people who were had births in the hospital. But in all of the situations, there are people who can come into the house, or you can see them at the hospital. Yes, if you're at the hospital, you get to see all of those people. Okay, and maybe you need to see them right away, and maybe you don't. But I have never met a midwife who didn't bring in a lactation consultant if there were any problems. It happens immediately, and I know a lot of lactation consultants who don't work in hospitals. They go into homes.
Yeah, well, I want to be clear that I am supportive of midwives, and I also want to be clear that I'm supportive of independent practitioners. Really, my question is more about whether the state feels that they want to regulate the delivery of those services when they're not happening in a hospital. And is that the reason for any hesitancy? Because it would seem otherwise like such a slam dunk. Why not? You know, so again, it's not a lack of values alignment here. So
no, it is not. I mean, the state feels so confident that the that the citizens, excuse me, that the residents in Massachusetts are going to be taken well care of, that they don't feel the need for a license. It isn't that they don't think that they're capable, it's that they know that they're going to get fantastic care and that everything's going to happen, so they don't feel that they need to put together a licensing board.
And like, I guess another component here, I wonder if there's like the entrenched beneficiaries of the system where the hospital is like, you know, because it's socialized to the extent that you're generally not charged for your actual cost of care. It's like the hospital over the population that it serves manages to pay its bills, et cetera. So like, you know, our hospitals pushing back against this because they don't want competition in the birthplace market.
Now, you also have the doctors who are delivering babies.
Taylor that's talking.
Very much against this.
I'm sorry, Janice, what did you say?
I said, I think one of the biggest oppositions to this are the physicians who deliver babies. The GYN, the obstetricians who are primarily against this. And I'm sure that it has to do with, you know, competition for them. The other point I'd like to bring out is that in inequity, when you have to pay for it yourself, Medicaid, a lot of these women who would like a home birth use Medicaid, and Medicaid will not pay for any service that the caretaker is not licensed. And the advantage for some of these people having a midwife is they get prenatal care and postnatal care, especially if there are complications. Whereas if they don't have health insurance and they don't have money, they go into the hospital, get delivered. They don't have prenatal care and they don't have postnatal care because they can't afford it.
I think that this is one of the issues that we see a lot. We take a simple thing, a license. The state didn't say, we don't want to give you a license, you can't practice here. The state said, hey, you've got this certificate, you are qualified, go for it. They accepted the midwives. But the insurance company requires a license in order to pay. This is truly a catch-22. Now, once we have the catch-22, all sorts of other people get involved because they think it's about something else than the catch-22. But in reality, this all starts out with a catch-22. That's my. And as much as I would like to continue this, and I want to continue this, let's continue this after we get through the M4A, because this is one of the priority bills. It's one of the ones that's most difficult to understand. And we're not going to solve this catch-22 by accusing doctors and this and that and what's better and other. What we need to do right now is get back to the program. And then at the end, we'll get back and we'll trash all of our doctors, our obstetricians, okay? Is that okay with everybody? We together? Okay. And Kathy, Michael, if you can put your thing in the chat, I promise we will get to you. Okay, M4A. This is an act to establish Medicare for all in Massachusetts. It's H1267S766. And what this bill really is a single payer health insurance coverage for all the residents of Massachusetts. And it is one of the Massachusetts League of Women Voters priority bills for the 192nd session. And before I do this, I have to say that I would ask each and every one of you to put a little note in your phone for December 12th at 12 noon. because December 12th is the United Nations International Universal Health Coverage Day, because universal health coverage is a human right according to the United Nations. And at 12 o'clock local time throughout the world, the United Nations asks that everyone on December 12th every year ring a bell. So if you got a bell anyplace you can ring on December 12th at 12 noon, please ring it. This is not an easy bill. It's not an easy bill because there's so much misconception. And one of the misconceptions that happens with this bill is that the name of the bill at this moment in time, 2021, is a misnomer. Medicare in this context is a misnomer. Medicare as it exists on the federal level and what this bill is about are different. And because this bill is named Medicare for All, people take one look at it and assume that they know everything about it. It doesn't matter whether you're a citizen, a resident, a lawmaker. It doesn't matter. A chief of staff. You look at it, you say, Medicaid, I know what it's about. And you don't. And that is one of the stumbling blocks that we have in this bill. And I want to point it out early on. It's also not an easy bill. We've already talked about the misnomer, because it is different from what we all know as health insurance. In the United States, we've only had one type of health insurance ever. And that's what we know as health insurance. And this is different. It's totally different. It's like comparing a zebra to a lotus. It's different. And because we only have the zebra to look at, it's hard for us to understand we're talking about a lotus. The other thing is that this bill is complex. So we get a misnomer in the name. We get the fact that it's different from what we know as health insurance. And it is complex. And we do what normal people do. We get frightened and we rationalize. So the normal reaction to this bill is fear and rationalization. And the normal questions that come up is, first of all, what's it going to cost me? Will I be able to get an appointment when I want it? And will it cover what I need? And you're not being selfish and you're not being strange. You're being normal. And those are normal questions you need to ask and you need to have answered. There are rationalizations to get away from something that's so scary and new. It will never work because it's going to bankrupt us and our taxes will go way up because we're thinking about what we know. And then we want to pull away from it. Why can't we wait? We'll do it slowly. Or as our fearless legislative leader did at the DOTH meeting, we'll let the feds do it. So let's talk about some of those things. Fear, what's it going to cost me? All right. Okay, let's get real. The first thing you have to remember, and this is a hard one to remember, that in M4A, there are no co-payments, there are no deductibles, and there are no premiums. Let me say that again. There are no co-payments, there are no deductibles, and there are no premiums. You need to remember that And when you're figuring out what it's going to cost you, you need to remember how much you pay in co-payments, deductibles, and premiums. Now, even though I am a capitalist, I don't like people thinking that capitalism is bad, but we sometimes think that capitalism is bad. And when somebody says something is progressive, some people say, oh, progressive is bad, okay? But this is not a bad progressive, just like me being a capitalist doesn't mean I'm a bad person. Those are just words. And it happens to be a description of the kind of tax that is used to pay for this type of coverage. A progressive tax, meaning that people who have more money get to pay more. Let's begin by talking about what isn't taxed. I put Medicare in there just for the fun of it, just to understand that Medicare isn't, meaning federal Medicare isn't part of this tax. Anything you might pay for federal Medicare doesn't have anything to do with this. Medicare on the federal level is not part of this. As a matter of fact, it doesn't exist in this. What is not taxed? Pensions are not taxed. Social Security is not taxed. Medicaid is not taxed. Medicaid doesn't exist. It's part of this thing. SSI, which is Supplemental Security Income, is not taxed. SSDI, Social Security Disability Insurance, is not taxed. Unemployment benefits are not taxed, okay? None of those things are taxed. What is taxed? If you are an employee, your yearly salary minus $20,000 is taxed at 2.5%. This comes out of your paycheck. So anything you make, you earn over $20,000 is taxed at 2.5%. And it comes out of your paycheck. And that's it. That's all you pay. If you are an employer with less than 100 employees, you pay 7.5% for every employee salary, 7.5% of for every employee salary after the first $20,000 earned per employee. If you are an employer with 100 employees or more, you pay 8.5% for every employee after the first $20,000 earned per year. If you're self-employed, you are both the employee and the employer, so you pay 10% in tax after the first $20,000 per year. If you have unearned income, that is taxed at 10% over and above the first $20,000 per year. In other words, if you have $20,010 in interest from your savings account, and you got one heck of a savings account, but you would pay 10% on that $10. And that's it. That's what you pay. And every person living in Massachusetts has what we would call health insurance coverage. This is from the House Bill, Section 19B, 1, 2, 3, 4. You do the math. Now, this gets crazy because we just don't understand this. What the heck's going on? All right, what's going on is this. If we have two people, two spouses, one works, one does not. They live in Massachusetts. The person who works pays 2.5% after the first $20,000 they earn, and both people are covered. They have children, children are covered. Example number two, two spouses, both work. They both pay 2.5% after the first $20,000 of their salary. They're both covered totally. All their children are covered totally. Everybody in Massachusetts is totally covered. Different animal. It's a lotus. It's not even an animal. Do the math. Okay. Will I be able to get seen in a timely manner? Will I lose my doctor, my hospital? The answer is, for the last one first, you will not lose your doctor. You will not lose your hospital. If you like the doctor you're seeing right now, fantastic. Continue to go to that doctor. If you like the hospital, no problem. Go to that hospital. If you want to change, change. It doesn't matter who you go to. You get to choose. In other words, it's total choice. Aha, you say, but I won't be able to be seen in a timely manner. This is the one that's hard for people to understand if they're not in the medical community. And especially if they haven't had to deal with prior approvals from the other side of the. Everyone has total choice. I'm going to read this and then we'll talk a little bit. Everyone has total choice over which hospital to go to, what doctor to see. You can change at any time you wish. There are no referrals needed. Your doctors still work for you and are paid by the insurance company, which is the trust that's going to be set up. The doctors are still independent business people, as are the hospitals. They're not working for the state. Now, there are reasons why you're not going to have to wait for, I'm sorry, I need to get something to drink. First of all, my daughter's an economist, so I know how economists think, and economists like to give you big numbers. But today we're going to try to do this not with big numbers, but with small numbers. Prevention of acute issues is one of the reasons that we will not have to wait around. And the enormous time that prior approvals take is another thing. And thirdly, your treatment is determined by you and your doctor, not by an insurance company. So I'm going to give you two examples. The first example is diabetes. type 1 diabetics have to have insulin. Now, there's an idea that's been floated around a lot. I first heard it from Dr. Arlene Ash. And the idea is that if we know type 1 diabetics need insulin or they die, and it's not a quick, easy death, there's lots of intervention. But if we know that, then why are we charging them for it? That each individual who has type 1 diabetes should get insulin for free. Now, in a system where you want to care about people, where you want to keep costs down, what you do is make sure that all people who have type 1 diabetes have insulin at all the time. Now, I don't live in La La Land, and I know that even if you give every person who is a type 1 diabetic insulin without any cost, not everybody, not 100% will take it, but a vast majority will. And all of the sequelae of people not taking their insulin are going to be decreased. Think about what happens when people don't take their insulin. There are heart problems. There are major blood vessels that are kidneys, kidney damage, eye damage, people going blind. Think of all these kinds of things that happen when a diabetic doesn't have the ability, a type 1 diabetic, to get his or her insulin. So by being able to actually do preventive things like insulin, it's just one example, which, by the way, the federal government is picking up on. They want it to be $34 a month or something. How generous. And the ability for the state to buy in bulk, then we're going to decrease a whole lot of unnecessary time treating things that don't need to be treated. So preventing acute problems by intervention and prevention. There is an enormous amount of time that is wasted on prior approval process. And instead of wasting your time, because I don't know who you are right now, we'll talk about that later on when we're talking questions. But enough to say that 50% of the time that doctors waste will now become available. In other words, in order to do prior approvals, oftentimes the number of times you see the doctor is doubled. Without the prior approvals, we get rid of that. Let's go on to rationalization so that you won't have to keep listening to me and we can talk and we can chat. One of the rationalizations is that it will never work because it will bankrupt us and then our taxes will go way up. Now, one of the things that people don't understand about our current system is that we don't have just a finite amount of insurance companies that we're dealing with. Well, maybe we do, but not insurance contracts. If there is company A who wants to have insurance for their employees, and they know of a big company, a big insurance company, Company Z, and they contract with Company Z to take care of their employees, then Company A and employee, the contract that company A buys from the insurance Z is unique. Every contract with every employer is unique. That's the way to say that. Let me say it again. Every contract that an insurance company writes for an employer is unique to that employer, meaning different things are covered. That sounds weird, but it's true. So that means that your hospital, your physicians are dealing with, conservatively, somewhere between 50,000 to 100,000 different insurance contracts on a daily basis. And those are not stable contracts. Those contracts change every 3 years, except you never know when they're going to change. It is a nightmare of pre-approvals that your physicians and hospitals have to deal with. A total and complete nightmare. If you can imagine the amount of staff time, doctor time, interfacing with all of these different insurance companies and plans, and take them all away and have to deal just with one company, you can see the saving in time. I'm not sure that, I think, I understand that really well because I had to deal with it for 45 years, but I'm not so sure I'm explaining it well. So we'll move on and perhaps we can talk about it more later. So the rationalization of an enormous amount of doctor time and staff time on interfacing with insurance will be saved. Insurance make a huge profit yearly in the tens of billions of dollars. The states can negotiate prices, so we will do that better. Duplication of services and inability to coordinate with each other are gone. Now, this comes down to antitrust laws. And we're not going to be able to get into that unless you want to in the chat later. But because of the antitrust laws that we have, there can be no coordination between hospitals or physicians. And if we get the state involved and the state is helping us to purchase everything, then suddenly the antitrust laws that have to do with businesses, which is what hospitals and physicians are considered, get in, let's just say, life gets easier. Why can't we wait? Do it slowly. It's sort of like, well, you can't change half a diaper at a time. Let the feds do it. Well, we know for sure that the next 8 years, the feds aren't going to do it. Biden has said that he won't. And if Biden is replaced by a Republican, it definitely won't happen. And also, the other thing is that with this type of a change, it comes from the bottom up. It's not going to come from the top down. If we're going to go from zebras to a lotus, it's not going to happen from the top down. It's going to happen from the bottom up. And, hey, we're in Massachusetts. We're still revolutionary, and that's where we are. And when we talk about this with the chiefs of staff of our legislators, one of the things that we want to talk about when they say, oh, let somebody else do it, or we'll do it later, is, and one of the things I do when I talk to myself and say, oh God, do I really want to keep doing this, is what's your number? You know, how many people have to die before it's time to do something? What's your number? And what's your time frame? I mean, are we going to count the people who died during the pandemic, or are we going to have a 3-month time range? And how many people have to be maimed, and how many people are going to get service? It's time to do something about this. It's really an inhumane kind of thing that we have going. And I think, what's covered. All right, let me just quickly go over what's covered. You can find what's covered in the House Bill, Section 15A, etc. And doctor visits, hospitals, drugs, all medical issues, disease, accidents, mental health, substance addiction, nursing homes, ambulatory care, ambulances, emergency medical care, hearing, vision, dental, specialists, all kinds, surgery, mental health. I put that in twice because this bill considers your mental health as part of your total health.
Yeah.
All reproductive care is including abortions. And I have here, no, this is too good to be true. What's wrong? I always feel like a snake oil salesman about now whenever I'm talking about, Medicare for all. And again, I would say that you have to remember that this is a different model than what we are used to for healthcare. It is totally foreign and we can't really comprehend it. It's sort of like me, who never really met my paternal grandfather, who drove horse teams for a living, and trying to explain to him, a 500-foot cargo ship with cargo from all over the world. The man who had to come spending time on a boat from Italy. Not a good example, perhaps, but there are many. We're talking about something very different. I would encourage you to read this bill. When you read it, read section 15, then section 12, next section 13, 14, 16 through 22, finally sections 1 through 11. And just so that you know, I'm not totally insane, and I do live in the real world. Numbers 1 through 11, sections 1 through 11, need work. Passing this bill is a huge first step. We have to get the bill passed first. Then we go on to the next step and the next after. Everything isn't going to suddenly change, and everything isn't going to be suddenly wonderful. But until we get this bill passed, we can't go on to step 2, which is forming the trust. And you know that the state is going to muck this up, but we're going to be here. And we're going to be here to make sure they don't muck it up. And when they do muck it up anyway, we have a silver bullet. And the silver bullet is called our vote. And we at the League of Women Voters know how to vote. And we also have to remember that one of the great silver bullets about this way of health coverage is that it covers every single resident of Massachusetts, which means that it covers every single voter of Massachusetts. our healthcare coverage.
Hello?
If we don't like it, we vote and we change it. So ask your representative and senator to sponsor this bill. Right now, it's in the Joint Committee on Healthcare Financing, and we'd ask you to please contact them and ask them to swiftly and favorably get this thing out of committee. And I have talked far too long. I thank you for hanging in there. Let's try to answer questions and actually have a discussion. And first, let's go to Janice, because she tends to be more precise than I. Janice, you want to talk a little bit about M4A and other such things? If you're with me.
I didn't hear you.
Oh, did you, Janice, are you with me?
Yeah, I'm with you now. Yeah, I keep losing you, but go ahead.
Okay. Do you want to add anything about M4A? I've been sort of wandering
No.
all over.
I think you did a good job. I think that
See
people
what a
need to-
nice answer she is? Go ahead.
can you hear me?
I
Yeah,
can.
I think people need to be aware of the impetus to privatize healthcare, including Medicare. And for those of you who watch television or the radio, note all of the advertising that's going on for Medicare Advantage plans, which are going to hurt Medicare. And also there's something called DCEs that are happening in 38 states where people on Medicare, unknowns to them, are being transferred to private accounts. All of this
Thank
is,
you, President Trump.
yeah. Have I been cut off again?
No,
Can you hear me? Okay. And I think
Yes.
this is more important that we pass Medicare for all in Massachusetts to prevent this from happening for us and allowing other states. I think there's 7 other states who are also trying to pass this law. This is the way
Right.
Canada passed universal health care state by state. And it would be wonderful if Massachusetts could be the first one. I mean, we started with Romney Care, which then became Obamacare. And now we sort of have Trump Care, which is what this DCE is all about.
Right.
So it'd be wonderful if Massachusetts could change it all and pass Medicare for all. And I think you did a wonderful job, Dal, so I have nothing more to add.
Janice is right. There's a cautionary tale here. December 15th maybe is the cutoff. I don't know. But Medicare has 4 parts, as you know. The federal Medicare has 4 parts. And 3 of those parts are privatized. There are subsidies that are given to the private insurance by the federal government, but they are private insurances. And Trump has allowed them, or the Trump era has allowed them to dumb down a lot of the Medicare private parts. And one of them are the Medicare Advantage. And they are going out crazy with all sorts of ads. And they sound wonderful. Talk about snake oil. They sound absolutely wonderful. And they don't cost anything. And they are very dangerous. They're fine if you don't get sick. If you don't get sick, they're wonderful. If you get sick, you're in deep doo-doo. So please be aware. Let your older relatives or whatever know to be very cautious about Medicare Advantage and understand that Medicare Advantage is changing. It has, so if you've had a good experience, years in the past, don't expect that that's what you're getting now. Taylor, are you with me? And how do you want to do this whole thing? Do we have some some
I can
questions.
give you the questions that we have that haven't been answered yet. I think I have two of them from earlier in the presentation that I can read for you if you wanted me to read them out, and then you could give everyone an answer.
Okay, and then after that, maybe we can get people to talk to.
Sure, yeah. And if anyone
That's
else,
not what we had talked about, but it doesn't look like we have more than about 15 or 20 people here, 20,
Yeah.
25 people. So maybe we can allow people to talk too. Okay, let's go with the questions that came.
okay,
in.
and if anyone else has any additional questions, put them in the chat and we can, add those to the list as well. So the first question I have, I'm not sure if we answered this just in the course of giving the presentation, but Kathy Michael asked, what kind of burden, both financial and time-wise, would licensing of midwives cost them?
I don't know the answer to that. I truly don't. That is,
Excuse me, Val, as I said, I did ask this when I was considering this bill, because the question had come up and it was answered. And I'm embarrassed to say, my mind cannot recall the answer. I think it was included in the bill. I'm not sure. So what I will do is I will look it up in my notes and then try to get back to you to let everybody know.
all right. So we will see to it that answer
Yeah.
happens.
Yeah.
And perhaps we can send the answer to all of the people who are here once we get it. Is that doable, Taylor? That should be doable, right?
Sure, yeah, we can put any answers in the follow-up email that we send to all registrants if you would like to do that.
Yes, please. Let's do that.
Okay,
We
excellent.
want to answer all questions. So any question you have, just stick it in the chat. But go ahead. What's the second
Okay.
question?
So Robin Chen asked us, she said she'd like to get a better understanding of why the family the family caregiver tax credit excludes under 18-year-old dependents. Why must age discrimination happen? Human lifespan has periods of dependency for activities of daily living. So why does the family caregiver tax credit exclude under 18s?
Janice did it.
Yeah,
I'm
because-
impressed.
Yeah, I think there is a protection for under 18 under a law for children. And I'm not, again, I'm going to have to apologize. My mind isn't 100%, but I think that there is a bill protecting children the same way. And I think that's why the law is written that way.
Yeah.
Again, that's something I guess we're going to have to look up. And
Yes, it
provide.
is.
Yeah. I wish my memory was a little bit better.
Well, I don't have the excuse you do, and I don't recall it.
Yeah.
Okay, it looks like we've got a couple of additional questions as well.
All right.
So Andy asked, I wanted to ask a question about the way you frame this benefit. Andy, did you want to elaborate on that a bit? Sorry.
Yes, I'm sorry. It's not Andy, it's Pamela.
Oh, okay.
Britt.
Go ahead.
I think the insurance industry wants to talk about this as insurance coverage, and we should not let them. We need to talk about this as its health care coverage, not coverage, health care, period. So instead of what we're getting is insurance coverage, what we're getting is comprehensive health care.
I like it.
So please don't fall into their language trap.
Thank you.
And I will put another article by an ex lobbyist for the health insurance company into the chat so that you can read about the tricks they used that worked. He's now a whistleblower. And it's very important because this is propaganda, this idea about choice. You need to emphasize that choice is higher when you have comprehensive health care and not a constrained insurance policy. Also, I just tried to figure out, I have regular Medicare And yesterday was the deadline to change my drug coverage plan. And trying to find out what the different insurance coverage things that I could choose cost is impossible. You can't manage what you don't measure, and you can't have a market when you don't have the information to compare. This is absurdly expensive. We've got to, not only is your program, don't say policy, don't say insurance, don't say coverage. Not only is your program better, it's also cheaper.
Yes.
And it will allow all of those people who are working for the administrative insurance business to actually get into healthcare and help the people instead.
Right. I love it. I love the fact that we can get rid of insurance. And you're way ahead of me on that, and I am going to follow your lead on it.
Talk about coverage, add comprehensive coverage.
Right.
And use that term instead.
Yes. I love it.
Comprehensive health care coverage. Yeah.
Okay.
Let me just add one little thing. I personally did not talk about choice because I get too snarky when I talk about it, as far as how insurance companies use the illusion of choice. You know, everybody wants to have choice, so they think they're going to get choice with insurance, and it's in all of their ads. And I get really snarky and I come off really bad. But your point is so well taken. One of the major pushbacks that you will get when you start talking about this kind of care, health care, coverage, is I want choice. I want my choice. Now, see how snarky and terrible I got? But that's one of the things that has been sort of ingrained through advertising into the population, that they will somehow have choice, which is ridiculous, with healthcare insurance. Okay, next.
Okay.
They get to choose the insurance company, but they don't get to choose their doctors.
That's correct. Some of them don't. You're right. This is a closed system.
Val, we do have some additional questions in the chat that have come in. If you wanted to tackle those.
Sure.
So we have two questions about Medicare for All. One from Kathy asking, are there examples of this model for healthcare working in other countries? And then one from Cynthia asking how many co-sponsors the bill has in the House and Senate, and where we can find a list of those co-sponsors.
Okay. The first part of that is no, there are no other like this. We have taken, or there that I know of, it's not like Canada, it's not like England, it is unique. But it is Massachusetts, United States unique. At least that's the way I look at it. And the second part of that was what?
How many?
Co-sponsors, how many?
Oh, co-sponsors, yes. I haven't checked that. I haven't checked it. The last time it came across my desk, it was 74. I'm hoping it's more now.
I believe it's 76.
76? Fantastic.
I think I read that yesterday.
Okay.
Mass Care does have it on their website.
Right. Mass Care has it on their website, and also all you have to do, look, go ahead, James.
And
Janice,
they're working on trying to get more co-sponsors. And
right.
And if you want to help support, if your representative or senator is not signing on, try to work on them.
And, you know, one of the reasons that we went through all of these slides and I talked forever is that when you call up and you talk to their chiefs of staff, they're not going to know anything about this bill. You got to get them to read the bill the way we told you to read the bill. And you've got to get them to understand that this is a different animal than federal Medicare. Because they don't understand it and they don't want to get involved. And especially when you're talking about representatives, we don't know exactly what's going on in the House of Representatives. Got a meeting going on sometime next week to hopefully find out more. But please contact your local representative and senator. Talk to them if you can. If not, talk to their chief of staff. Try to get him or her to act like another human being. You are a human being. Now that the person's a human being, get to them at the human level. One of the nasty things that I do to these poor people who give so much time to us is ask them how many people have to die before their representative or senator will change things. Give me a number. What is your senator's time frame? Give me a number. They don't like that. And as Kathy Leonardson knows, I can be a real pain in the butt when I get going on things like that. But push them to read the bill. Let them know that you care about it. It's important. The more signatures we have, the more sponsors we have, the better chance we have of getting this thing out of committee.
Yeah,
And,
the best way that I know of getting your senator or legislator to sign on is the number of people who call them. What they want from you is their vote.
yeah.
And we were actually able to change our legislator from the Harvard area by having a mass calling and talking about she was up for re-election and this is what we wanted. And she did change her vote and she signed on to the national bill. I came from Harvard, which I was very lucky, both the senator and representative were for it. But I'm now recuperating in Clinton. And I was shocked when I called the senator and the representative here, and neither one of them even knew about the bill. And so now I'm trying to work on them. And one of them did say to me, how many of my constituents support this bill? And since I'm in a strange area, I'm now trying to find out the answer to that, which shows what they're really interested in is the vote. If they're going to get voted on because their constituents want it, they'll vote for it. The competition that you have is money. I once did a study on how many of the representatives and senators who developed Obamacare were paid off by the healthcare industry. And it was mind-boggling, the amount of money that was spent to prevent Medicare for all or universal health care. So it's vote versus money.
To add to that, something came across my desk the other day from the Galvin, Secretary of whatever state, Galvin. And for the last 6 months, I don't know how he does that. It was something like, I want to say $800,000 had been spent in lobbying just by this is just the state legislature for 6 months on lobbying from 2 different health insurance groups.
CVS
That's a lot of
has
money.
actually paid $1 million to an organization to fight this bill.
Oh, it's absolutely. And they have the money. They have billions of dollars.
Yeah.
They have billions of dollars in profits that they have to report. But they hide a lot of money for sure. So anyway.
So I personally am now boycotting CVS.
Yeah, you know about CVS. Yes, CVS is now involved. Do you want to go there? Go ahead, go there.
We also have a hand up currently from
Go ahead.
Barbara.
Oh, hi, Barbara.
Barbara, did you want to?
Hi, yes, can you hear me now?
Yes.
So I just actually decided to put it in the chat, but I just thank you so much, Val, for this and your joint testimony and your testimony on Capitol Hill Day in favor of Medicare for all. And I really respect your reason why you say that it's different, that Medicare for all is so different from what we know as Medicare. But there are some senses in which it's valuable to make reference to the fact that we have Medicare. It's not a foreign thing. We know Medicare. It was when I signed up for it, I just signed a piece of paper. That was it. And then it started going that way. And so it's not like it's some foreign, strange thing that the United States can't do. It's been doing it for years and years and years, just needs to improve it around the edges at this point. Anyway, that's I hope you agree on that. And I hope that everybody else who had the experience of signing on for Medicare had it as easily as I did. The Medigap, I did need to have help from my employer, but it was so much less than if I had had all these other plans. And I guess what's making me so mad now is I get all this stuff from Medicare.gov selling me Medicare Advantage, which is, why are they giving it away? Anyway, I will go on forever, but I just wanted to, those of you who are interested, I work with a national group of a national network, ad hoc network of healthcare reformers around the country. And we're trying to do something pretty exciting for next convention. So I'm going to put my email in the chat and I hope people will contact me. Janice knows what I'm talking about. I guess Val does too. And I hope we're going to be able to make some progress on this, both at the state level and the national level. There. Thank you. Thank you for the time.
Thank you, Barbara. I think it's very important that we all understand that our goal is to have this as a national plan.
But in the absence of one,
it appears at this moment that we need to put our eggs in the state basket.
yeah, the way Canada did. The way Canada did, they started in one province.
Okay, we have a hand up from Kathy Michael.
Hi, thank you. Thank you for all of the work you've done. I hate to take this back to a less important topic away from Medicare, but back to the midwives. I guess I feel pretty strongly about this because my daughter had 2 home births out of 3, and there's no comparison to the absolutely amazing care that she got from the home birth. As you said, gold standard. So it makes me nervous to think that there could be unintended consequences that we have not thought about, such as if a midwife needs to be licensed, does this mean that a new midwife, a new person going to getting licensed, does not also have to have the gold standard certification, and that insurance company? No? Okay, explain that.
You have to have a CPA at CPM. CPM, is it? Yeah, I don't have it in front of me. That is a requirement for licensing. That would be the requirement.
All right, I'm glad to hear that.
No,
because there was no comparison in the skill level.
No.
Okay. All right.
That is an absolute requirement for licensing in the state of Massachusetts. That I mean, Massachusetts mucks up a lot, but on that, I'm sure they will not muck up. That is something that really needs to happen. And that's not an unimportant bill. It's a very important bill. We want to have equity throughout the system. But it also brings us back to the fact that, if we had Medicare for all, if we had medical coverage for all the residents of Massachusetts, we wouldn't have this stupid problem. You know, it's a stupid insurance problem. One of the other things that happens with insurance is that they delay. And they delay and delay and delay to the point where you give up, or some people give up. You know, you have to be an incredibly determined person to get your money from insurance companies.
So that's right. So it seems to be much more of an insurance problem than a midwifery licensing problem. So if
It
we could
is.
only, so are you saying if we get Medicare for all, it would just be moot. It wouldn't even matter.
Correct.
That'd be awesome. That would take
It
care
would
of
be
it.
awesome, but if we get Medicare for all, it's going to take us from the point of getting the bill passed. It's going to take us 2 to 3 years at least, maybe more, to actually set it up and get it going. Passing the bill is the first step. Huge, huge, big step, but it's the first step. And then we have to have the trust established. There are some large laws that have to be discussed with the federal government. So there are a lot of things that have to happen after this bill is passed, but we can't do anything until the bill is passed. And between that time and the fact that we get Medicare for all, we want to take care of our citizens, and we want to have all of our pregnant women have the possibility to have at-home births if they are having a normal birth and they are a healthy person and they want to do it at home. We want to make sure that they can do it at home. And because you hit the nail right on the head, it's just an insurance problem. This is a catch-22 insurance problem. It's stupid. It's a stupid insurance problem. It's not having a number to stick in a stupid box. That's what we're trying to take care of with that bill. That's it.
Thank you.
What's happening, Taylor?
I don't think there's any new questions in the chat. If anyone has any additional questions or comments, you can put them in the chat. You can raise your hand if you'd like to raise your hand.
I have my hand raised.
Sorry, I don't see any hand raise reactions, but it looks like you're unmuted, so go for it.
Hi, this is Dr. Lauren Andrade. I'm retired nursing professor and pre-med education after 44 years. I just want to say I did a special testimony on Medicare for all, and I appreciate everything that was presented today. And Valentina, you exceptional. That's all I can say. And I would like this education that's being shared with our league sisters and brothers to be shared with the masses. People do not understand any of this. If we don't educate them, they will not know about these things. I'm out here talking at churches, on Zoom, to other organizations, and we've got to do a little better at the league. We've got to bring it home, put it on YouTube, get a hold of someone at your local TV stations, talk to your radio people, get this information out so we can educate the masses to get the support that's needed. Or else we're going to be right where we all are. And we all got everybody that I can see here that I could see at one point. We all have white or gray hair here. So I know for a fact myself, with my health at a decline at times, I don't know how much longer I'm going to be here, but until God takes my last breath, I'm going to fight. So please, let's do better with educating the masses. Thank you.
You're welcome. Let me share something that I often share with my students when I was mentoring. Insurance, to understand insurance as it exists right now, any kind of insurance in the United States is technically legalized professional gambling. A professional gambler always knows the odds and never makes a bet unless he or she knows that they can win. Weird, but true. Insurance is legalized professional gambling. And that's okay, as long as you understand what you're getting into. And the insurance companies in the United States, including the ones that are health insurance companies, are very good gamblers. And they make huge profits, but they always control the odds. And one of the neat, or not so neat, horrible things that happens, and Janice and I both know about this, and sometimes we have trouble being quiet at LAC, the Legislative Action Committee, that if we see something that isn't right, and somebody else sees it too, and they say, oh, we've got to make a law so that the insurance companies can't do this anymore. And the law passes. That's great. But, you know, I have white hair too. And I've been in the business a long time, and I know something. And what I know is that even if we pass that law to prevent that insurance company from doing that, it will only take them 3 years with their lawyers to circumvent in their contract that law so that they can again control the odds, because their contracts are about 3 years long. So if you understand the enemy and you understand what they're about, then you have a better chance of winning. The problem is that because they are good at, and they have, you know, ad people and whatever, they let you think you have choice. You don't. That they care. They don't. They're only in it for 3 years. And over again. So we'd like to think that our consumers, our residents, are swift enough to understand this, but it's very difficult because there's so much ads, so much misinformation.
Oh, yeah. Yeah,
So,
definitely.
legalized professional
Yeah,
gambling.
I agree with you 100%. I will just say this. There was an old cartoon and it used to state, if you can't convince them, confuse them. And that's what this is all about, confusing people. But to me, if you get small groups of people and educate them, at least they can make a better informed decision. If you don't reach out to do that particular thing, then things just go awry. And remember, these insurance companies, these gamblers, where they get their money from? We're supporting them. We're paying this. This is coming out of our paychecks. So,
It's also coming out of your taxes.
and taxes,
It's coming out of
exactly.
your taxes.
And
Because
taxes,
the federal
absolutely.
government is paying them. The state
Yes.
government is paying them.
No, that's
The
what I'm
state
saying.
Yeah.
If we educate everybody and we let them know, we're not going to let you get away with this anymore. This has got to cease. Things will change. I do believe that things could change.
Remember, healthcare has lots of money and everybody wants a piece of that money. Everybody but the poor patient. I mean, there's a lot of money going around and it's not going to the patient. And I think
No.
we do have to be careful because I don't think entities will ever give up trying to get a piece of the pie. You know, there's a tremendous amount of money involved in healthcare. And they
Yes.
don't care, people don't care whether it goes to the people, they want a part of it. And we can put one to sleep, another one will wake up and fight for it. So I think the American people have to be vigilant forever.
Oh,
You
absolutely.
also have to think systemically
Mhm.
and not individually.
Yes.
which is why Medicare for All, not just Medicare for All, that's why Bernie Sanders labeled his program Improved Medicare for All.
Yeah.
But he fell into the trap of talking about it as though it were insurance too. It is
Mhm.
health care,
Right.
But
comprehensive universal health care.
Okay.
Please, everybody should read that article by Wendell Potter,
yes,
because he shows exactly how the health insurance did it and is currently still doing it, and will give you impetus for how to talk about it to counteract them. I understand how you wouldn't want to talk about choice, but actually you should talk about choice because you offer it. Insurance companies don't.
Mm.
They conflate choice of insurance company with choice of healthcare, and they're entirely different.
Of course.
Yeah.
We're getting towards the end of our
But there's
time.
one more thing. When we talk about the costs of the system, there's also a difference on what the total cost is and who's paying it. And right now, the costs are not shared in any kind of fair manner, no matter what viewpoint you have. Because the costs, the main part of the costs are on individual people.
Yeah.
And a lot of individual people simply can't afford healthcare, period, because they can't afford to live. They don't have enough for rent and food.
Mhm.
And this kind of healthcare isn't paid by individuals. It's paid by all of us.
That's right.
So the
Fantastic.
cost. for
Pamela, thank you. Thank you. We're
Right,
going to get
right.
cut off. I'm sorry, did you?
No, I was
That's
just going to say, I
talk
worked on
about who
universal health
pays
care
the
when
cost.
Hillary Clinton, back when Bill Clinton was president. I used to go to Washington every single week on the red eye, working on universal health care that we could not get through.
Yeah,
Right.
you know, I think she took the wrong lesson from that. Her
Yeah.
lesson was, well, we can't do it. Instead, she should have taken the lesson, we didn't do it right. We need to do it differently and get it done.
Okay, I'm going to stop everything right there because we're going to lose this Zoom time.
Well, thank you all. Thank you so much.
I want to thank everybody. Janice, do you have anything that you would like to say as a wrap up for a couple
no,
of
I
minutes?
just want to thank you for taking over and doing such a wonderful job.
Well, I don't like being here alone, kiddo, so get yourself back together. It's so good to see you. I want to thank everybody for coming. I want you to please, Taylor, when is this going to be up for people to be able to read all of who they have to call?
So when we are going to send up a follow-up email, probably tomorrow.
No, I mean, when is this this video going to be available?
Likely tomorrow or Friday.
Oh, okay. All right. So if you are confused as to who you're supposed to call and when you're supposed to call them, by all means, look at the video. Go to, if you have any questions that didn't get answered, by all means, contact the League of Women Voters and we will try to answer them. We thank you very much for coming. This has been a wonderful session. Thank you, Kathy Leonardson, for setting this up. I know I have learned things and I thank you so much for listening to me, and Janice, and for being here. Taylor, again, thank you many, many times over. Thank you all.